All right, if you've been in pharma QA for any length of time, you know the old rule, right? 10 parts per million. It was simple, sure, but was it actually scientific? Well, the industry has made this huge leap forward, and today we're going to unpack that revolution in cleaning validation. We're talking about the move from these kind of arbitrary rules to some real hard science. So here's the change in a nutshell. We're basically leaving behind those old arbitrary limits. You know, the 10 parts per million. Super easy to calculate, yeah, but not really connected to actual patient risk. The new way? It's all built on science-based toxicology. We're using concepts like health-based exposure limits, that's HBEL, and the permitted daily exposure, or PDE. It is a complete, fundamental shift in how we think about safety.
So you gotta ask, right? Why the change? What was the big push? Look, it wasn't just about updating some regulation for the sake of it. No, this was a fundamental reevaluation of how we protect the very people who rely on our products. It's all about putting patient safety front and center, at the absolute heart of everything we do.
Okay, so to really get a handle on this new world, we have to start with the health-based exposure limit report. You can think of this document as like the DNA of your cleaning limit. And buried inside this report is the one key piece of information you absolutely need, what I like to call your golden number. And that golden number, well, that's the PD, the permitted daily exposure. Now, the definition you see here is absolutely crucial. This isn't about a one-time thing. We're talking about the amount of a residue someone could be exposed to every single day for their entire life without any negative effect. Just think about that for a second. That is an incredibly high bar for safety. So how in the world do toxicologists even come up with this number? Well, it all starts with what they call the point of departure. This is usually the no observed adverse effect level, or NOAEL, that they find in clinical studies. But they don't stop there. From that point, they apply a whole series of safety adjustment factors. These account for all sorts of things, like the differences between animals and humans, and even the variability among people. It's this really rigorous process that gets us to that final, scientifically solid PDE value. So, after all that science, all that number crunching, you get your final number. It's usually in milligrams per day. And when you get that tox report, believe me, this is the number you're looking for. It is the bedrock for everything else you're going to do. Now, this whole new approach means there's a new key player on your team. You know, back in the day, QA might have just handled all this on their own. But in this world of HBLs, you absolutely need a new expert partner, the toxicologist. Seriously? Think of the toxicologist as your new best friend in risk assessment. They're the ones who are going to dive deep into all that dense clinical and non-clinical data. They're the ones who can tell you the specific hazards of a drug, like is this thing a mutagen, a sensitizer? And here's the real kicker. When a health authority inevitably challenges your cleaning limit, you're not just going to point to an SOP. No, you'll have their expert clinical reasoning to back you up. That's a game changer. All right, so we've got our golden number from our toxicologist. Fantastic. But what do we actually do with it? How do we turn this scientific number into a practical, real-world cleaning limit for the manufacturing floor? Well, that is where the MLAC calculation comes into play. So what is a MACO? It stands for Maximum Allowable Carryover. And the goal here is pretty simple, actually. It's the absolute maximum amount of gunk or residue from product A that we can safely allow to be carried over into the entire batch of the next thing we make, product B. Okay, let's build this formula. The very first piece we need is the PDE of the product we just finished making, the one we're cleaning out. This is our golden number, remember, the one we got from the tox report. It's the safety foundation for the whole calculation. Next up, we need the smallest batch size of the next product we're planning to manufacture. Now, why the smallest? Simple. It represents the most concentrated worst-case scenario. Think about it. Any tiny bit of carryover is going to be at its highest concentration in the smallest possible batch. So we plan for the worst case to make sure we're always safe. And the final piece of the puzzle is the maximum daily dose of that next product. This is critical because it tells us how much of that product a patient is actually going to take in a day. It puts the whole carryover question into a real-world clinical context. And here's how we put it all together. The MACO equals the PDE of the last product times the smallest batch size of the next product, and then you divide all of that by the maximum daily dose of that next product. See? It's a pretty simple and elegant formula, but it's incredibly powerful and, most importantly, scientific. It's how we really ensure patient safety. Now listen up,
because this is a really important pro tip. If you're in a multi-product facility, and most of us are, you're going to be calculating a MACO for every possible switchover from one product to another. So to make sure you are always, always safe, no matter what you're making next, you have to take the most conservative value. That means you find the smallest MACO you calculated, and that becomes your overall cleaning limit.
Okay, let's just zoom out for a second. This whole shift, this move from 10 ppm to HBEL, it's not just about learning a new formula. It's about a fundamental commitment to the science of patient safety. It's a whole new mindset. And the benefits? Oh, they're huge. We are finally moving away from just picking a number out of thin air. We're creating cleaning limits that are truly science-based and totally defensible. And you know what that means? It often leads to more efficient cleaning cycles and definitely smoother audits, because you've got solid data to back up every single decision. But really, the most important benefit of all, it gives the absolute highest level of protection to the patient. And that's what this is all about. So, there you have it. We've walked through the what, the why, and the how of this whole cleaning validation revolution. We've gone from arbitrary rules to real toxicology, from simple limits to a scientifically justified MACO. So the real question I have for you is this. Now that you're armed with the science, how are you going to champion patient safety in your organization? How are you going to be the one to drive this change forward?